So the first tip I have is that you need to identify the key dynamic that needs to change, ideally by the end of the first session, and certainly no later than the end of the second session. And what I'm talking about here is using clinical case conceptualization to identify the 1, 2, maybe 3 key dynamics that need to change in your client's life. And so what I'm not talking about here is, oh, they've got depressed mood and I need to reduce it. Or they've got anxiety, I need to reduce that. Or this couple or family fights too much and we need to reduce that. I'm not talking the very simplistic behavioral, obvious goals that you don't need a degree in this field to identify. So you don't need a master's degree, 3,000 years of experience, or a doctorate to know that someone who's depressed needs to reduce their depressed mood. What I'm talking here is identifying why they are depressed, why they're anxious, where the conflict is coming from, where the symptoms are coming from at a deeper level. So, for example, just the other day, I met with a new couple, and your goal, especially with a couple, is to identify that interaction pattern and where they're getting stuck, who's got the roles in this, what are the roles in the system, and why is this couple stuck? And their pattern was actually not too unusual. If you're using emotion focused couples therapy, there's the concept of the burned out pursuer. And so this couple, I was able to do it in the first 10 minutes, where it was very clear what was going on. I knew exactly what to do. And it didn't, and by the end of the session, ideally you can identify that core dynamic within, the first 30, 35 minutes, so that at the end of the session of an intake session, your first session, you were delivering them a conceptualization of what's going on, or at least the initial developments at such a deeper level than, they experience. They're usually very surprised. The couple I was working with at the end of the session, they said, wow, we went to therapy for, weeks and weeks with another therapist, and we didn't get this far in like 10, 20 sessions. So because I was able to crystallize what was going on, see what was going on so quickly, because I was able to conceptualize. And this particular couple had a pretty classic, it's called the burned out pursuer. If you're curious about that, you can look that up in emotionally focused couples therapy. But even with depression or anxiety, being able to identify what is going on, either behaviorally, cognitively, emotionally, that has them, feeling depressed or anxious. So, for example, a client I was working with who had a lot of both depressive and anxious symptoms, when I was able to talk with her, and, again, you're often just tracking that interaction cycle, but it's, or the cycle of the behaviors and thoughts around the symptom, getting a detailed description of that typically helps. And so like with this one client, it became very clear that there is this internal dialogue that she has around body image that really fueled most of her kind of depression, hopelessness, and anxiety behaviors. And we also did identify that there was a seasonal issue, seasonal affective disorder is part of her cycle too. She had 2 of those things going on. And again, she had been in therapy many times, many years before. And at the end of the session, just by identifying those 2 different ways that she basically does her depression, she was like, wow, that was so clear. And your clients leave with a sense that you get them, you understood them very quickly, you understand the core of their dynamics, you're able to explain to them what's going on in a level they couldn't understand. And it really just shifts the whole thing, and their level of hope goes up, and they're much more engaged in the process. And so it's going to be much more likely to be effective. So that is my number 1 tip.
I'm going to stop it there. Anybody able to respond to this number 1 tip? Because I'm thinking you might be able to think along those lines, but probably you don't have much opportunity to really explore that with your clients. Tell me what you heard and how it relates, if at all, to you.
Okay.
Thank you.
So in listening to it, I agree with what you said just now. It is a bit difficult because I know for APS for our position, we're not in the home too long. So you're in the home for about an hour. Some clients you might be in the home for about 2 hours. So in that time, you're looking for. I know that how she talked about not more so the superficial type of help, but I think with APS in that time, you're looking for the superficial type of help until you can actually dig a little bit more deeper in time to see like, and really look at the case to realize like, oh, this is really what they need help with. So I think with the position we're in now, it is a bit difficult to not just identify like the initial help that while you're there, like, oh, this person needs help with electricity. Like this is the main focus right now. Of course, there's something deeper. But because we're in the house such a short amount of time, we're initially looking at what do they need right now. So I think trying to incorporate that where it's like you're looking for what they are looking for at a deeper level would be a little bit harder to do in this specific position, if that makes any sense.
Can anybody respond to what Rajana said?
Yeah, I'll respond. Um, I, I, I'm sorry. I'm sure I see Ross.
Yeah,
Um,
yeah.
so I kind of agree with you, but however, I think something else that we kind of do also is, basically going back to the same example, which you said, if a client is struggling to pay the electricity bill, yeah, I understand the problem right now is helping them, get that paid, but I want to know how they got to that point.
Mm-hmm.
So what was the reason? Did you lose your job? Like, what happened? What happened to your money? So I want I want to dig a little deeper to figure out what happened. And a lot of times, even though, my immediate supervisor always says that if we are able to help a client, we want to make sure that we put them in a position where they're not coming back for the same services. So
Yeah.
that's why we have to identify the reason why to get to that point first, and then, hopefully um provide them with information or put them in a position where they aren't in the same position. So in a sense, yeah, it kind of feels that way immediately, and a lot of our cases does feel that way. But in addition to that, there's certain situations where we dig a little deeper. So, but I think the only thing is like there's times where clients may need certain things that we're not able to provide for them immediately. And for that reason, it just makes it difficult for us. And there's also times where clients, you have to respect clients' autonomy. So even though you identify what the concerns are, the client may decline certain services. Even though you know what the problem is, they'll tell you they don't want to seek any further treatment. So, and there's nothing you could do at that point. So, I mean, yeah.
I have a question on that real quickly because I like what she says about the end of first session. But I've noticed like with the clients I currently have, I've had clients where we go in, we identify what the issue is, and like you said, how they got to that point. But I've noticed when I sit down and I really have that time, when I go back, I notice that how, oh, this is the deeper reason as to why the client is where they're at. And sometimes I feel like the first, because of how what we're doing, sometimes we're not even in the homes that long. Some clients may not want you to be in there that long, or you're in there maybe an hour, hour and a half, because you're going out to other homes as well. So I've noticed like sometimes the difficult thing is finding that dynamic that needs to change in that first session. because a lot of times our cases are open for about 30 days. They're short-lived. So I think it's like, how do you do that for these type of cases and finding that? Like, I understand asking the questions, but yeah, like.
Well, your job, all of you actually, your job does not include what we're going to be focusing on: assessment, the conceptualization, the development of a treatment plan, the delivery of the treatment plan, and then the evaluation. That's not your job. However, that is going to be your job as a mental health professional. So you've got to develop this awareness now. Spiff and Liz, you have the luxury, shall we say, of having longer term clients. And I know both of you have been engaged in some of this work. Can you talk about that?
You want to go first, Biff, or you want me to go?
You can go, Liz.
Okay. So, so in my current position, I'm doing field visits monthly, but previously as a continuing service worker, working with parents and kids who have already been removed and in foster care. So in that role, and even currently too, even if I meet them on the first visit, I start where they're at. I know typically in advance, like what the most presenting pressing issue is related to, like for kids, their placement stability, if they're depending on how they're disrupting the balance in the house. And then I look at the systems piece of it too. And then I go in there and just have a conversation. I engage them. I start where they're at, and then I let them just talk. And so from there, I feel like we're able to build a relationship. And so we can get to where they feel safe enough to trust me within that hour span of time that we have, sometimes hour and a half. And then kind of just dig in and jump into what the issue is. Not necessarily.
I'm going to interrupt.
Oh, go ahead.
And tell you a little bit later this morning, I'm going to share with you what Diane Gayard says are the two most important things that you will do. Number one, establishing a working relationship, an alliance, a connection. That is the most important thing. You said that wonderfully. I sit down and let them talk. Rashana said, you know, when I have a moment, then I reflect on everything that I listen to. Number one is that alliance. And number two is this whole business of conceptualization. Why are they having these difficulties? What is driving them? So that you can formulate a meaningful plan.
Well, and then in that too, currently when I go out and do my field visits, I'm not able to move forward and provide further support necessarily. I can circle back and offer to see those clients again in the future, which I have been for the most part. So I'll see them like an ongoing basis in a couple months. And then we already have our relationship established, so they feel more comfortable with me. But outside of that, then I just go back and I provide recommendations, and I talk to the social worker, or I talk to the supervisor, I talk about services that are needed. So I bridge that gap. So that's my role and how I do that.
I think with my client, it was a really different situation because I worked with him in an auxiliary space before I started working with him directly, but because I supervised the social worker who had his case and then the interns who had his case. So I would see him and I would engage with him, but it was really like their client, their case. And a lot of, I know over those years that I was in that capacity, the focus was always on my client's education. He needs to finish high school. He needs to finish high school. He needs to be going to school. That was like the key focus that everyone really focused on. I took over the case when he turned 18 though, which that changed because I knew he wasn't going to finish. And after 18, it's not a requirement. He doesn't have to go to school. So when I asked him if he wanted to be my client, because we had the option to transfer it to an ongoing caseworker or keep it in, like I could keep it for licensure. And I told him, I said, if you work with me, we're going to be doing some therapy. And he's like, I'm not doing therapy. I was like, okay, well, you know, meeting with me, you will be, you know, but so it, you know, that changed our I guess I'm saying it doesn't really quite fit into the typical assessments. And when you're trying to do your first session and get to the root of the cause, but it was more of like letting him know this. I knew school wasn't going to be our focus. Our focus was going to be building his relationship with his caregiver and like interpersonal skills, because I think that's where a lot of the deficits I saw in just being in supervising his case. So I kind of let him know like that's where we're going to be starting. And
would it be okay if you shared about his dirty boots?
yeah.
Because even though that seems like a
Yeah.
minor,
No, that's
it really involved conceptualization.
yes. Yeah. So my client is 19. He'll be 20 in a month now. And when we first started working together, he wasn't working. So we were really focusing on like his depressive symptoms because it seemed like that not working really affected his self-esteem and identity. But once he started working, he's been like that all changed in terms of identity and esteem and depressive symptoms. But the biggest fight he was having with his caregiver is he works in a roofing company and he would come home and have his dirty boots on and walk through the house. And so her biggest complaint every single time I saw them was he won't take his boots off. He dirties the house. He doesn't care. He doesn't do any chores. He's not trying to be a part of the family. He won't eat at the table anymore. Like, so she had these lists of things. I was like, really, like the hardest thing to do is to get him to take his boots off. Like that became our focus. So for a few months, I would pick him up from work and drive him home. He spends money on Uber. So he takes Uber to and from work every day. So it adds up to $600 a month. So part of the way I would catch him was like, I would just tell his caregiver, I'm going to pick him up today. I would show up at his work and pick him up and take him home. That would be our time to talk. And for probably a year, we talked about why he needs to take his boots off before he comes in the house. And I told him, you know, I know a lot of professionals in the construction field and in roofing and in all of these fields that you're interested in, and they all have extra boots. Like they keep them at their office, they keep them in the car. Like these men don't come in the house with those boots on because they know how dirty they are. And he like knew that, but wasn't really, just was like, who cares? Why does it matter? And so finally, like the breakthrough came when a lot of the work I did was with him and his caregiver too. So we were doing like family sessions, and his caregiver finally said, I feel like it means you don't care about me. And that was like the one thing that finally like let him know, like, she thinks you don't love her, don't care about her because you won't take your boots off and respect the floor, you know, or just not track in the house. And so since then, she said that things have been better. There's still times where he comes in and I've caught him, but he's much more conscientious of it. He's much more aware of it, to the point that last month I picked him up And he looked at the car and he was like, "Oh, my boot, like I'm really dirty today." And I was like, "It's fine. We can clean the car." He took his sweater, put it on the floor so that his boots wouldn't be on the floor of the car. Which to me, I was like, is that your way of saying that you care about me in this car? Or like, but just please be doing that consistently at home, because that's what I need you to do. And so most of the work that we've done, and just something very, very simple and basic like that, helped their relationship, because the frustration was coming between the two of them, where he doesn't know how to bond and really show care and affection, and he has very um, machismo ideas of man-women relations and household duties and things like that. And it was causing a lot of conflict with this caregiver, who would tell me consistently, like, he's like my son. I'm never asking him to leave, but like it's really frustrating. And she finally got to a place where she was sharing that, she was separated from her husband. My client was actually exhibiting a lot of traits that her husband did um, in their marriage. And so there was so pinpointing some of that too, that she was projecting some of that onto him, that he shared more about his childhood and what that looked like, so that she could understand, like, no, his mom stayed home, did all the cooking, all the clean, like his stepdad worked hard and didn't do anything when he got home, and that's what he was expecting when he came home, even though they're in a parent-child relationship, not a partnership. So yeah, but the boots, that was like one thing that when I was talking to the both of them, that seemed to be like one um tactile thing that we could focus on, that I was like, if I can just get you to do this, we can work on the other things, if you can understand what that means, like what taking off your boots means. So Latif, I saw your hand.
You've done, I believe, a good job of hypothesizing why this kid has these problems. The lack of nurturance, the lack of attachment, so that people can be treated like boots. And you really have helped him move a little bit forward in terms of being able to have a more secure attachment. Do you agree?
I hope so. Yeah, I think so.
So let's go back to what Rashana said. She said, hey, this is hard. I only have one visit. Well, I attended a seminar with a famous group psychotherapist, Irvin Yalom, and his unit of work was one session in a psychiatric hospital.
Mhm.
And I would say that was probably tough too. But if you develop your ability to hear and see and feel dynamics, that's really what we're talking about here. In the very first meeting, I'll tell you, until I met him, I used to think people are going to come back. We have time. But when I met him, I said, Jan, make every session, do the best you can to make every session possibly life-changing. That sounds bodacious. Maria, any comment you want to make about this idea of identifying key dynamics in the very first meeting?
Um, I think it's possible that we can with children's services because we do, we do want to find out what the reason is for either, because right now I'm in continuing services. The main reason as to why the children have these behaviors, if they're having behaviors, or with the parents, what's the reason as to why the children were removed and why they continue to relapse if they're using substances. So I think this is a good one to take with me every time I do my initial assessment with them on my first meeting with them to, the first or second, even the second meeting with them, just to continue to see what is going on with them and not bring them back to the system.
It makes my head hurt sometimes trying to really understand. Now, Emily, you work in hyper crisis mode all the time. So this is quadruply difficult. Can you speak to this?
I've had some failed moments, I can say that. And I can recall, and this is how I'm kind of seeing the connection with trying to figure out, like in the first session, like if you're not building that alliance and that empathy with like the clients, they're not going to disclose what's going on. They're not going to want to be upfront with you. And I've learned this. I've had some challenges where like for me when I get into when I get information about like high profile crisis cases, of course I want to get to the root of it. And I think the downside for me sometimes is that I've already got information from other people about the dynamics that I think that this is what this kid is going through, but not necessarily understanding it from the child's point of view. So like in one particular case, I can say that, and Jan, I know I had spoken to you about this case before. Like we had a kid who identifies as a male, but biologically he's a female. And this kid had been at the Welcome Center for like 150 days or more, right? And of course, I work a lot behind the scenes with trying to figure out, okay, why isn't this kid responding to any prompts? Why isn't this kid wanting to do this? Why isn't the kid wanting to do that? And so I'm hearing it from like different people, from the worker, from, like the mental health providers that are in with him at the Welcome Center, from people, staff that are supervising him day and night. And so, when I got on the phone and I was trying to first talk to him to see what is it that you need? Like, what is it that I can do to help you so I can understand so we can help each other? And, I think my first conversation with him didn't go very well. He didn't want to talk. And it's because I came at him with like, just questioning him and not really taking the time to get to know him. So, I think when that failed, it made me think, right? Like, what is it that what can I do differently? Like, and then I guess in my situation, I was trying to think outside the box, but really, I wasn't even in the box because I wasn't really giving this client an opportunity to like allow him to trust the process, to allow him to trust me, to allow him to open up, because like I just didn't allow that space for it. So, like in another meeting when I had with him, it was those moments where, I had to kind of reset the tone and just say, look, our last meeting was horrible and I apologize for it, and it just explaining, the purpose of me being here, just the just how I want to connect. Like I want to feel like I want to ask the right questions and connect so that way I can understand what the needs are. And I think once he understands that, I'm seeing something flickering, he slowly kind of opened up towards the end of the session to kind of let me know what's going on. And it turns out, people are pressuring him to take a bath. People are pressuring him to go to school. People are pressuring him to stop self-isolating. People are pressuring him to, do all these things that he's uncomfortable with doing. But the root of the problem is he's uncomfortable with himself, especially going through the gender change. When he wakes up in the morning, he doesn't shower because he doesn't feel comfortable seeing his body, the way he sees his body. So he doesn't shower. He doesn't want to go to school because he doesn't want to, interact with people because he's ashamed. He feels ashamed of his body. So like there's little things that through our interview and like that I've gathered that made me understand like, okay, the root of the problem is this. And once I was able to reiterate and just even like paraphrase what his words are to what my understanding is of his words, just in simple terms, it kind of like I saw like head shaking or sometimes at some point I was trying to be funny and like I saw a little smirk from this kid who normally won't give you any facial expression. And so I think, going back to like that tip number one, where you have to kind of understand like just like the dynamics, right? Like of why they're in there and what is that the core, like the root of the issue. You have to like connect with clients for them to disclose and divulge all this information, to you. And without that, they're going to be closed off. And, the relationship, you might not get much from just what you see, So it was challenging for me working with this kid because, I had to check myself because I had some biases myself as well. And I was hearing information that was feeding to me from different people. So I had already formulated an opinion, um, without even talking to the client. And when I was able to check myself and just kind of start from like a blank sheet of paper and say, okay, look, let me hear it from you. I want to hear your story, And so like just that, I think it allowed him to open up for me. And I remember when I went over to the Welcome Center, I knew that he likes to drink boba, so I was trying to like bribe him with boba, and he knew right away. He's like, I'm not going to talk. You can just leave that drink right there on that table. I'm not going to eat. I'm not going to drink it, And so it was like, okay, so I'll just leave it right there on the table. So and so it was he knew what I was doing, but I think later on it was my ability to just be real with him and just say, look, I know a whole lot about you from other people, but I don't know a whole lot about you from you. So I just want to hear it from you, and then that, had helped me set the tone. But, he's no longer at the Welcome Center. So, and he's doing really well.
Well, there's so much to respond to in everything that all of you are talking about. Lateef, I know that back in the day, you had a lot of experience with adolescents and building a simple connection. Anything you want to say about that?
Yeah, I think I agree with what everything everybody said. But one thing I've learned is that sometimes just sit there and let people talk. Literally, just listen. People will tell you what they want you to know, and from that information, you'll be able to figure out what the issues or concerns are. And that's something I practice every day. So whenever I see a client, the only time I literally stop people is when they start rambling about things that has no relationship or connection to whatever we're talking about. But a lot of times I just let people talk. People, you'll find out. And I think that's it. I mean, I don't know. I think that, yeah, that's all. I'm sorry, I'm a little off today, so I'm just trying to get myself together. It's been a long day.
That's right. It's early.
Yeah.
So I think we're getting agreement about the idea of, if you will, clinical social work being quite different than social work. And you have to develop eyes, ears, and a heart for not just listening, but being able to decipher what people are saying. And you got to do that quickly. You got to do it quickly. Because Rajana and Latif frequently have only one visit. So all of this, your ability to see dynamics will improve if you insist on making yourself view this. That sounds kind of funny, but you need to push yourself. What's going on here? Not what are the problems, but what's going on. Just back to what Spiff was saying. Why is this kid stomping through the house with dirty boots? And then be able, if you have the opportunity, to make an intervention. And when you do an intervention, that's A1. And Spiff did that with the foster mother and the child in a meaningful way so that the child could hear. It makes me feel, what did you say, Spiff? Unworthy, unvaluable.
Cared about me.
Pardon?
She said that you don't care about me.
You don't care about me. And that struck a chord. So shall we go to point 2? Is that okay? I won't go through the whole tape, but we'll just get a flavor.
So number 2 is do not confuse your client saying they feel better or feel supported with being effective therapy, because some of the most ineffective therapy I've ever seen, the clients do feel better at the end of the session and they do feel supported in therapy, but nothing is changing in their life. And there are some clients who will pay you to just make them feel better, and they can come in every week and, you know, they can tell you how mean everyone's been to them or how bad life is, and you're going to empathize. They're going to feel better and they're going to be willing to pay for that, you know, on and on and on and on. But most clients don't do that. They don't keep coming back for long periods of time. And nothing's changing, nothing's getting better. And it really becomes hard to build your practice, especially if you're working in a private practice environment, if things aren't changing in their life. Because sometimes you need to actually make clients uncomfortable. They're stuck because they kept doing the same thing over and over and over again because they're afraid to try new behaviors or, you know, change, grow, develop when they need to. And so oftentimes our job is to make people uncomfortable. And I would say that's especially true in couple and family work, but it's also very true when you're working with anxiety. If you just think of, you know, the evidence-based treatment for, you know, OCD is exposure therapy, and that is just all about making your client uncomfortable, because you're going to expose them to what scares them the most. So you need to be really thoughtful about and aware of, and to have the courage in some cases to make your clients uncomfortable so that they can change. And when we're not going to obviously sit through the whole session and make them uncomfortable. And we do want them to feel supported and we do want them to feel better. But there are times where our clients have to feel uncomfortable to achieve the change that they are seeking. And we as therapists have to be willing to let that happen.
What do you think about that?
I'll talk.
Thank you, Daisy.
Hello, good morning. So that was interesting that it's stating that courage to make clients uncomfortable to achieve the change that they are wanting in the future. Sometimes I myself feel uncomfortable to address what's really going on, to portray in their face, like, how did this come about? How did you get to this point? And then they're saying, other things, but it's not like the root. Sometimes they kind of either mask it or minimize it, or it's not my fault, it's this person's fault, but it's in reality, whatever they make their, lives to be, they're putting themselves in that situation. No one's making them to do X, Y, and Z. They're allowing it to happen, or, whatever situation it is. But that's interesting that, that, like that statement, courage to make clients uncomfortable to achieve the change. But, knowing that, when I go see clients, they state to me, I'm so glad that you came here. I'm able to, I don't talk to a lot of people. Thank you so much for giving me time to speak. And then they feel a lot better. And then I address to them, we're going to be having a working relationship. I'm going to be there by your side to provide whatever resources that we can do this together, but I need you to do your part as well. So kind of teaching them to be independent, but, having me to the support that you're able to make the phone calls, or able to do this, or able to access mental health. That you're telling me that you need assistance with depression that you're talking about, but you have to be willing and, accepting that help, so I think that's a great tip to, like, remind myself, the courage to make them uncomfortable. Because, when you come in the house, you don't know them, you want them to feel comfortable to talking with you. You're building that alliance. Then when you come at them and, like, making them uncomfortable, they might feel standish. So it's kind of like, trying to, weave yourself around, trying to, get to find them the bigger picture of what's going to happen in the future, I guess, working with you.
Sometimes
Yeah.
the way I handle that, Daisy,
Mm-hmm.
is I will actually disclose. I will say, I'm really scared about what I am about to say, because the last thing I want to do is upset you or that wonderful connection that we're forming. But there's something I feel I really need to talk about that kind of scares me. And that saying both parts of it, our relationship, protecting that, but also that I recognize this could be disruptive. So that's how I tried to deal with that. Anybody else have a comment?
I have just a quick comment. Ultimately, for me, I think it's just about accountability. And, if you're coming to me for a service and identify what the concerns are, and, it's okay, you can, it's just accountability. I'm providing you a service, and my service just to make sure that, your needs are being met, or whatever concerns you have is being addressed. And so we have to be able to have an honest conversation. So I'm not going to be a yes man. I'm not just going to be a yes man or woman. You know what I mean? So we have to be upfront about each other, similar to how you tell me what's going on. I have to be willing to tell you you know, what you need to do to make situations better for yourself. So if you're not willing to take that approach, then you have to live with the consequence at the end of the day. So for me, I don't know. I just think it's just all about accountability. And
Maybe that also is because you're a Marine.
I guess, you know, and I'm very direct with my approach,
Yeah.
so I don't like to beat around the bush. So
Yeah.
I mean, you know,
But you know, Latif, I was thinking when Daisy started speaking that there are some cultural barriers. I think of Asian populations where it's offensive. It's, you're bringing shame. You're embarrassing people by pulling the covers off. So, yes, you have to have your own style, the kind of man you are with your own lens, how you see things. But it can also be complicated because of culture. Anybody have a thought about that? Or am I out on?
No,
No,
I
I
agree.
just, oh, good.
Go ahead, Daisy.
Oh, no, no, go ahead. I already talked already. Your turn.
I was gonna say I agree with that. I feel depending on what culture you go into, it can make it harder to bring up some topics. And some cultures are a bit easier. Um, I know I have a lot of cultures that are more so Middle Eastern. And when it comes to talking about things openly with if the female and male is there openly about like sex or things of those matter, it is a bit more uncomfortable bringing that up because of the background and the family and how the family dynamics kind of work. And then also like even talking or speaking with in some families, speaking to just the female, if we need to speak to the individuals separately, that sometimes become kind of like you're kind of stepping on eggshells, or it becomes a little bit uncomfortable even for myself asking for that, because you understand how the culture may work, or like the individual may not want to speak to you like, oh no, my husband needs to be here, or oh no, I need to be here for this. And you don't, and even though you're trying to do your job, you're not trying to overstep, and you're not trying to cause more harm to the client or more harm to the situation or make it like uncomfortable. So I could definitely see how culture plays a major role in how we would go about dealing with those situations.
You're right on about that. It's delicate and it can blow up right in your hands. Your best effort. So being culturally sensitive, aware, delicate, understanding. And by the way, when you're under the pressure of time, that's challenging. Maria, any thoughts about this? About your clients feeling better, feeling supported, maybe at the expense of real effective work?
Like you said, I'm still drinking my coffee. I'm still asleep. But I mean, like what they were saying about the culture, yeah, I understand. I do deal with a lot of Hispanics because I'm bilingual, so I usually get all the Hispanic cases, and I have had to have had some difficulties with some client, with actually just one client who they're foster parents and the husband wants to do all the talking. And I asked the wife questions, but he wants to respond. So I'm being very respectful about that. But there's stuff that I do have to get from her because she's with the child 24 hours where he's at work. And I've had to explain to him, this is what I need from her. And I'll politely direct myself to her again, and then he'll finally allow her to speak. So I try to do it very respectful and explain to him the reasons why I need to speak to her. And he understood. And at the beginning, he was very, the machismo type, being very sarcastic with me and trying to talk down to me. And I let him know that's not going to happen. You're not going to disrespect me. You're not going to, put me down. I will be talking to you and your wife, and I want the respect that I'm giving you. I want it in return. And at the end of the meeting, he did feel a little bit more comfortable, and he did calm down, and he was allowing the wife to speak at the end of the meeting. So it took a little bit, like tugging and pulling, but I was able to accomplish what I needed.
Well, I would say, the expression, the proof of the pudding is in the eating of it. And for him to move to a more appropriate in terms of
still sleep.
I don't know who that was, but I would say that kind of behavioral change is proof that you had the right amount of aggression, assertiveness, but probably support too.
Mm-hmm.
Relationship building.
Yes.
So good job.
Thank you.
So we're going to stop. Do you guys like listening today? Is that helpful? Since she's the author of our book.
It's very
And that's
helpful.
actually her, right?
That's actually her.
That's actually her. Okay.
And she's at Cal State Northridge. There you are, Spiv. And, she's a live person with a life, and she's a mother and family member, and she's a brilliant clinician. She is rolling out a new idea about synthesizing all major theories into their most common factors. So if you like her, we can jump in again. You can find this if you wanted to watch the rest of these tips on your own. So now, God willing, we are going to go to our presentation, hopefully. Don't you love it when technology works? Let's see, I gotta move that. I didn't want that, but oh well. Do you see one screen or two? Beans.
I see your presentation, and on the side, there's the next slide in the notes section.
Yeah, I don't know how to get rid of that. So we're just gonna suffer. So I sent you a kit this last night. And it has those really important documents. One of them is a narrative about conceptualization. And that goes with the fill-in form. And this will probably make your head hurt. But what this is being able to look at an individual, a couple, or a family, and be able to formulate using the lenses of the major theories that we've covered so far and the essential elements of those theories. You probably didn't have time to print those, but I recommend, you know what, I could do that, but let's just, let me see if this, hey, now what, I guess I have to do it with this. And why is that being that way? Okay, there it is. So the agenda in the remaining 45 minutes has to do with giving you a glimpse into assessment, which you are most familiar with. Your work with psychosocial assessment covers a lot of the material in an assessment. Next is the bear of conceptualization, the most complicated. Diane Gayart says, I don't want to scare you away, but I want to be truthful. She says it took her 10 hours to do the first one. And then thereafter, it was much more familiar and rapid. The treatment plan is relatively easy once you have a conceptualization of what's driving these problems. So that's what our agenda is. Would you be willing, Emily, to read this nice and slow?
Yes. Introduction. One thing that separates a great counselor from a friend, bartender, or hairdresser. What each does with the information that is shared by clients. After hearing a heartfelt story of struggle, friends, bartenders, and hairdressers tend to do either give advice or offer sympathy.
This is a profound statement that separates social workers from clinical social workers. What do you think about what Diane is getting at here? Anybody?
What I was thinking is that everybody plays a different role, and based on the role, that determines how, information should be handled. Obviously, having a conversation with a friend and then talking to a therapist about the same matters, has what's the word I'm looking for? Carries different weight because of the professional role or the settings.
Yes. Anybody else? Rajana, you're on mute. Rajana? Or maybe she's... Rajana? I think she's doing work. Anybody else? What I think of when I see this is that you and I can fall prey to giving advice or being sympathetic, which is human nature. just like a hairdresser, a friend, or a bartender. We can fall prey to doing that because people are hurting. Maria, would you read this?
What you do with what you hear. Counselors and therapists do something very different. They develop a deeper understanding of clients, often a more sensible and compassionate story than clients tell themselves. When therapists listen to clients, they take the information that they are hearing to develop a map of the person's experience and inner world. The inner map is called the case conceptualization and is the key to skilled component counseling.
Competent counseling.
Oh, competent counseling, sorry.
That's okay. So the key here is what responsibilities we have to do with all that flood of information. Anybody respond to this?
I think it's like we always want to go to the why. I don't like as social workers, and sometimes it's like when we're in public, we have to remember that too. Like if our hairdresser's talking to us, it's like, oh, just give a sympathetic thing. We don't have to get to the why of her story at this moment because I'm not a social worker. I'm a client in a hairdresser's chair,
Right.
you know. But I think that I mean, that's, you know, that we talk, I think it was last week, Mariana did a case conceptualization. And like one of the first things she said, you know, Miska asked for feedback, and I was like, well, it sounds like this probably happened in her childhood. It's like we can always go back to like what's happened in their trauma, what's their trauma history, what's their trauma timeline, what's the family of origin look like? Like that's where I think we all go when, and sometimes we have to turn that on and off in our personal and professional lives so we don't do it all the time, because sometimes our friends just want us to listen and not delve into the why of what they're saying.
But it's important to remember hairdressers, bartenders, friends have no ethical or legal responsibility to do anything.
Mm-hmm.
Yeah. That's that's literally what I was about to say. So no legal ethical responsibility. You know, you could tell your barber, for example, you know, about committing a crime or, you know, about to take your life or something like that. You know, I mean, a compassionate or, you know, barber probably tell you don't do it, try to talk you out of it. But, you know, as a professional, I have to take all the measures. I, you know, will have to maybe call the cops or, you know, just take extra measures to make sure, you know, actually stop that individual from following through with their, you know, thoughts. So like as you said, no legal ethical obligation, you know, as compared to someone within a professional background.
Emily, were you about to say something?
I was just gonna say very similar to what everyone else had already said. You know, because I think the difference really is like with the counselor, you can actually they dig a little deeper and try to understand the why. And you know, like what I've noticed also too is that sometimes through talking with you know, just through talking your experiences, so clients, you kind of make clients understand and see the connection, like the puzzle pieces. Because sometimes, like, you know, in face value, you see you see the problem as what it is and is what is presented in front of you. But sometimes as when you start to kind of dig and deeper into that, you kind of see the pieces kind of come together. And that's something that you don't get from a hairdresser or a bartender through those conversations.
Right. Latif, would you read this? How about you, Elizabeth? Would you read this?
Sure. Primary reasons we need theories. Develop a clear understanding and meaningful picture of what is going on inside the client. Counseling theories provide unique lenses through which to view the problems the clients bring to them. The counselor fits the pieces of the puzzle together via conceptualization and then determines the best treatment path.
Is this good news for all the work you're doing on learning those darn theories? There's a purpose? Anybody want to respond to this?
I can respond.
Oh, sorry. Go ahead, Elizabeth.
So I was going to share. So since I've been digging into chapter 13, getting ready for the presentation next Wednesday, I see it actively, and in the conversations through this group supervision, I see the connections of these theories and how they play out. I find likes and dislikes amongst a lot of different pieces, like hearing the different presentations over the last several months. And so it resonates with me because in all of our conversations, I keep thinking back to narrative counseling and touching on that and the pieces of how it just ignites my brain in different ways. And so it makes it more interesting. By the way, I actually like that theory, so I'll be excited to share out on it. So it's a benefit. So I think, I don't know. So hopefully you guys see it next week too.
Did you say you're beginning to see how these puzzle pieces come together?
Yes. So for example, when we were talking earlier on about the alliance formation, or that tip from tip number 1, when it was to identify a key dynamic that needs to change by the end of the first session. In my head too, I was thinking about, okay, well, in narrative counseling, something that I learned was that we separate the person, we meet the person where they're at. And it's not about meeting the person separate from the problem. Those are two different things, two separate relationships, and how the client sees one and the other. So that's just one example of like things igniting and pieces falling together, and then building on that theory and then what we're learning right now in this moment, the conceptualization piece. So that's kind of how it brings it all together for me.
Well, just kidding, but I would say you pass.
Oh, good.
If you keep working at this, it's going to come together. It's challenging, that's for sure. Would you read this, Spiff?
The primary goal is to be able to view a single case from multiple theoretical perspectives.
What does that mean? Do you have a thought about that, Spiff?
It's just, there's no cookie cutter way to treat someone. Because we really take, like, when you said Diane Gayhart's trying to get all the theories down to the root of what they all are, I was like, yes, because it's all meaningful in different ways in different moments. For all of our work, we can't just look at it from an ecological perspective. We can't just do motivational interviewing. It's like you might be able to do motivational interviewing in like the first 10 minutes, and then you're moving into more grounding and trauma work, and then ending with goals and plan and future planning. So you have to go in and out of all of it in every interaction. You can't just come into one session with one idea and this is all we're going to do.
I think it's difficult. It's a difficult concept because there's so many different touch points, like you're saying, there's an overlap. And so it could set your brain on fire with like, oh, this theory would be great for the solution focused therapy would be great with this, but that doesn't necessarily work with my negative client. And so I feel like to be refined in that scale, of course, we need to have like a broad ability to touch on different theories and to apply them, but do we know how to apply them the way they're meant to be and what will work for the client effectively? So it's such a delicate balance. I feel like we're walking on a tightrope here.
And as I was preparing for today, I said, if I was in your shoes, I probably would have forgotten what the heck psychodynamic psychotherapy was about, or Fritz Perls, or because that was a long time ago. And we're up with new. In fact, we're touching on narrative next week. So it's a monster amount of material. But if you look, number one, it's a 10-page document that I made. Don't be thrown. But it's a summary of all the theories. Only 10 pages. That goes with the forms. And the forms are really drilled down into their simplest, elemental, meaningful elements. And it's great review for you as you move out of supervision into your clinical exam and licensure. And it equips you to become a more skillful clinician. I've probably told you to beware of the 50-hour rule. Has anybody heard of that? What that means is, and it should make all of us be scared. The 50-hour rule means that virtually everyone that gets licensed and begins practice within the first 50 psychotherapy hours, they start falling in to a pattern, whether or not it helps clients. And they will do that into perpetuity. I don't hear anybody screaming. We need to beware, because I too have fallen prey to that until I started supervision. And I said, what the heck is it that I do? And is it different for each client based on their needs? So anyway, you're going to review multiple theoretical perspectives. And that's good for you, good for me. So, Daisy, would you read this?
Okay, two most important tasks is forming a strong working relationship and developing a case conceptualization.
Both of those are challenging, but vital. So in your kit, Latif, what do you have in your kit? Oh, he's probably still. Rajana, are you with us? Okay.
I am. Sorry.
Hey, would you read it?
Yes.
What's in your kit?
The clinical kit is 1, narrative on integrative case conceptualization, 2, clinical assessment fill-in, 3, counseling case conceptualization fill-in, and 4, treatment plan fill-in.
So for the rest of your life, if you won't like them in the beginning because they're kind of overwhelming. But if you push yourself, you can use these for the rest of your life. By the way, we all are required, as part of being a licensed professional, to have documentation. This would be wonderful documentation. But number two, it would be wonderful documentation if you get into trouble. If you are hear from the BBS about a complaint. Some people have no chart. Some people have an empty chart. If you do this, you will have substantiation to your clinical work. Would you be willing to read this, Liz?
Clinical assessment. All mental health professionals make a clinical assessment, speak the language of mental health professionals, monitor for safety issues, monitor for psychiatric and medical issues that warrant attention, perform a mental status exam, and make a diagnosis, case management, and make referrals.
Liz, does that sound familiar?
Yes, it does.
Yeah. So this one is not going to require much of an adjustment. Just getting used to the format. But the material, you're generally navigating when you do a psychosocial, right? So the specific terms, Spiff, would you read those?
Clinical assessment is client data, presenting problems, the mental status, diagnosis of identified patient, medical considerations, risk and safety assessment, and case management.
I might warn you, every clinic you ever go to will probably have a different format. But they all want to reach in and get the same data. Does that make sense?
Mhm.
It just may look different. So that's kind of the skeleton of clinical assessment. Maria, would you read this about the elements of case conceptualization?
Elements of case conceptualization. It's very tiny on my end over here. Let me see if I can move it up to a different screen. Introduction of the clients. Define who the client is, individual, couple, family, and identify most silent demographics, age, ethnicity, language, job, grade, etc. Presenting concerns specifically, how will parties involved are defining the problems, clients, family, friends, school, work, legal system, society, etc. Background and information, summarize recent changes, including participating in events as well as related historical background. Do this in sensitive way so the client will have a positive impression of and hope for themselves. Strengths and diversity, identify personal, relational, and spiritual strengths, as well as resources and limitations related to diversity issues.
So that's the first four. Spiff, would you read these?
Number 5 is theoretical case conceptualization. Use one or more of the following to develop an initial theoretical understanding of the client's personal and relational dynamics. Psychodynamic Adlerian conceptualization includes defense mechanisms, object relation patterns, Erickson's psychosocial developmental stages, and Adlerian style of life and basic mistakes. B is humanistic existential conceptualization, expression of authentic self, existential analysis, and Gestalt's contact boundary disturbances. C is cognitive behavioral conceptualization, behavioral baseline, ABC analysis, and schema analysis. D is family systemic conceptualization, family life cycle stage, boundaries, triangles, hierarchy, complementarity, and intergenerational patterns. E is postmodern and feminist solution-based and cultural discourse conceptualization. Previous solution, unique outcomes, miracle question, dominant discourses, identity narratives, and preferred discourses. That's a mouthful.
But that's everything distilled that we've been reading all the time in group. One little page. And these, back to, can I go back? These 4, and then these models, that's on the case conceptualization form. So every time you do it, you're reviewing all the theories and their essential elements. Again, I don't hear anybody throwing up a ticker tape parade, screaming, going, wow, that's going to help me remember. But this is, I never had anything like this when I went to school. You were on your own, buddy. So again, if you do this every time, you will be reviewing all of those theories in abbreviated form that will help you see where the problems are located and what theoretical orientation is going to be most helpful. Anybody want to say anything? Or am I going to cry?
I was just going to share. So thank you for that, because I was looking at, I didn't print out the document, but I'm looking at the case conceptualization narrative handout that you gave us, and I'm excited. There's so much detailed information. It's going to be extremely helpful. So thank you.
It is 10 pages, single spaced.
That's okay. It's good information.
But it's better than reading the whole darn book. And the reason I did it was twofold. One of them was I wanted to separate and make distinct these theories. But number 2, I thought if I was struggling, you might be too. And this could be helpful. Way more than you're going to need to pass the test, but not enough to be an exceptional therapist, which is what I want for you. Any other comment? Or the rest of you going, I'll read this at bedtime. Spiff, you usually have something to say.
I don't.
Oh, okay. Daisy, would you read this?
A summary. Case conceptualization is at the same time the most complex of clinical tasks, as well as the most exciting, since it opens the door to the unfolding treatment plan.
I don't know if you get the idea, but I believe that with all my heart. Because once you understand what's going on, the doorway opens of what to do about it. As long as you're continuing to build that alliance to support the work. So finally, thank you for your patience and attention this morning. There we are. So there you have it, start to finish. Your clinical kit, what do you think? Joke, joke, joke. Is it a lot to digest?
Yes, it is. I'm not gonna lie. I'm waiting to get my book. I ordered the book, so but it is a lot to take in right now. But I'm excited and excited to see all the presentations because it definitely helps me in, seeing visually and hearing it from other people. That's how I learn. So thank you
Daisy,
for everyone.
are you new to the group, Daisy?
Yes,
don't
I
think we've
am.
met.
Yes, I just
Welcome.
started. Thank you.
I'm so sorry I didn't introduce.
Nice to meet you guys.
It won't be so overwhelming after you've been doing this a while.
Okay, thank you.
Serious, like, because when we do the theory groups, going through the book, everyone does a really good job of presenting it, and in a way, like, we try to read along and be prepared, but if you don't, you can still follow along. It's not like, nobody's like shamed for not reading the chapter. It's like, no, here's everything you would need to know, snapshot of it, and then we talk about it. So it gets a little less overwhelming.
Oh, okay, thank you. Thank you for telling me that. Thank you.
No, I got all that case conceptualization stuff from you, Jan, last night, and I started the meeting this morning freaking out, like, oh my God, did we have to do that? Like, I definitely didn't. So, and so, like, obviously it's good practice, but we don't come in and everybody presents a 10-page case conceptualization for their cases here. So
Bravo that you opened it.
Mhm.
That's the first step. What
Yeah.
is this? And challenging yourself to see, could this help me?
Mhm.
I have a color printer, so printing it in color makes the sections more distinct. Liz, were you going to say something?
Mm, yeah, I was thinking about if I wanted to share it.
Oh,
So I'm presenting next week and I'm enjoying what I'm reading, but it's like two theories in one, and they're not overwhelming and they're not massively complex. At least, to be honest, I only know the first part of narrative. I haven't started the collaborative part, the second part of the chapter. And so I'm finding, because in general, I'm hard on myself. So to share the information with you guys and figure out, I don't want to overshare, and I'm not going to crowd the PowerPoint with words because I don't want you to tune out and just read slide. I'd rather engage you and know a little bit more about it. So I feel like it's a humbling process, and everyone who's gone before me has done really well. And so I'm just not nervous. I just hope that it meets everyone's liking. I don't know.
It'll
So,
be great.
We'll do fine.
Yeah.
okay.
When I started, we weren't even doing PowerPoints. Like,
Oh,
so I think one person did one, and then it just became the standard. Like,
That's
before,
true.
when I started, we weren't doing PowerPoints. We would just read and come to group and review it. So
That's true. I think my first groups, I just kind of read off of my notes.
okay.
yeah. And I think the PowerPoints have been really helpful. So I can't remember who exactly started it, but we all kind of said, like, oh, that's a good idea. So here we go.
And then in general, I think that it's a fine line between getting the information. Like I was looking at the summary notes that you'd sent over, John, And then what I was already kind of doing in general, I think I overshare. So less is sometimes more if it's just explained in a very simple way. So I'm trying to keep to what do you need to remember? What's the most important? So this is an interesting process because it's been like, I don't know, 10 years since I've been in school too. And so I feel like it's definitely, it pushes us back to like, I need to study, I need to this, I need to that. So it's interesting.
It's good refreshers.
I'm struggling because I want to say something, but I certainly don't want to put you on the spot, Liz.
You could do it. It's fine.
Well, but she just said a bunch of stuff
I did.
about her upcoming presentation. And this is what I want you to, not that we're analyzing each other, treating each other. No. But Liz said some things that we could begin constructing conceptualization. That you feel anxious about presenting, part of it because you're out of school 10 years. Part of it is that deeper issue of being hard on yourself. Does that resonate with you, Liz?
For sure.
And that's my beginning way of working in the area of conceptualization. Not that I would ever treat you, but the idea is these themes and issues keep emerging until we work on them and work them through. Was that okay to say that?
Yeah, I'm not put on the spot. Like I said, I thought about it before I shared and just I decided to share. It's not a big deal.
Okay. So I don't have to worry about being
No.
fired, which can happen. But does that make sense? We're just listening.
You just did tip one, which is getting to the root of the issue in the first session. So,
Good.
And whether we know it or not, whether we like it or not, you cannot not disclose. So our clients disclose, we disclose. We think, oh, I'm the professional here, but they know they've diagnosed us within 3 minutes, right? So lean into that. Like I said, I felt so embarrassed when I sent you that stupid link where you had to pay for the forms. I just thought, oh my God, what am I going to do? So I just fell on the sword and said, I'm sorry. I'm just getting back in the saddle. Please forgive me. And I didn't get any aid mail. But we reveal more than we realize, maybe more than we want. But if we keep working on ourselves, it's okay. Any final wrap-up thoughts for today? Daisy said it's a lot, but Spiff threw her a lifeline and said, each month it'll get better. Latif, you're probably the soonest out of school. Is this like no big deal?
No, it's funny you say that, but it is a big deal actually, because I was glad to be out of school. So now just the thought of it makes me feel like I'm back in school again, and I'm not looking forward to it. So, but I mean, thanks again, Elizabeth, for taking my spot. And it just gives me a little bit more time to start, hopefully I have a 3-day weekend coming up, so that's gonna be my goal. I think I'm gonna get started on my presentation now because you guys definitely set the bar high. So I'm not sure if I'll be able to, you know, get to that level, but I definitely need to start working on my end as well. But no, no, I'm not looking forward to it, but I will definitely try my best.
You'll be fine.
Yeah.
There is no
You'll be
bar.
fine.
I mean, everybody's been great so far, so I'm like, man, you guys are.
Well, Liz, it's not mandatory that you do both.
Oh, well,
You can
thank
say,
you.
you can say narrative is a big enough bite for me.
Oh, okay. I'll challenge myself to do a little bit more, but I'm going to take that lifeline too. So thank you.
Because, we want to be fluid, flexible, understanding. And Maria wanted to present anyway, right?
I just started, but I don't know. We'll see.
I'm just kidding. So, Emily, we'll miss you next week.
Sorry.
Do you want to, doggone it, shall we set up August? Is Wednesday the 2nd of August?
That's good. That's okay.
That's okay with you, Emily?
Yes.
And Latif, you get top billing? Latif, am I on mute?
Yes, I can hear you.
So is that good for you?
I can make it next Wednesday.
The August group,
Oh, August group, yes, yes,
and that will mean you're presenting
yes.
unless you develop yellow fever or something.
No, I should be good. I'm ready. I think I'm ready.
And that is what theory?
Um, can I email you on that? I forgot what it was that I presenting on.
Does anybody have their book around?
I have it. It's chapter 14, Feminist and Multicultural Counseling and Psychotherapy.
Okay. By the way, if life happens to you, cases blow up, emergencies, and you can't present, I can always share a Diane Gayard video. We only did 2 of her tips today. If that's a lifeline for you. Anything else? Oh, probably no next week. This group. And honest to God, you could hear me okay? Okay. See you next week.
Bye.
Bye.